morning, everyone. Good afternoon and welcome to our webinar about engaging the private sector in delivering healthcare and goods, governance lessons from the COVID-19 pandemic. The private sector played a key part in the COVID-19 pandemic response across Europe, and its resources and expertise were leveraged to enhance the delivery of health goods and services and contributed to the overall resilience of health systems. However, this collaboration was not universally positive, and it did present challenges, particularly around the issues of transparency and accountability. We now have useful evidence on how to support operational success and maintain financial probity in resource allocation and spending. So what were the policy successes and failures in engaging the private sector? How can we maximise positives and minimise the negatives? What governance lessons can we learn to ensure transparency and accountability going forward, not just in emergency situations, but more generally? Engaging the private sector in delivering healthcare and goods is a frequently controversial topic, but one that needs to be explored in a measured and informed way. So it is really exciting to have you all here today to get better informed and to gain real insight into what happened in different countries and what we can do moving forward. So to do this, we have a great panel of speakers today. First up, we have Gabriele Pastorino of the World Health Organization Regional Office for Europe. He works there and leads the health systems governance work within the Division for Country Health Policy and Systems. And Gabriele was one of the co-authors of a recent policy brief engaging the private sector in delivering healthcare goods and governance lessons from the COVID-19 pandemic. And please do feel free to go to our website and download the policy brief. Now, Gabriele will provide an overview of the key findings from the policy brief and touch upon some of the many interesting case studies that were included. And then we have two excellent spotlight speakers who will be taking a closer look at some of the specific country examples. We have Sarah Burke from Trinity College Dublin in Ireland, where she is Director of the Centre for Health Policy and Management in the School of Medicine. Sarah will focus on arrangements in Ireland early in the COVID-19 pandemic that sought to rapidly expand hospital capacity by tapping into private sector capacity, an approach taken in quite a few European countries that has important learning points for all. Next up, we have Anna Moresso, who is a member of the Observatory's Berlin office based at the University of Technology in Berlin, and one of the co-authors of the policy brief. Anna will be describing a case study on hospital procurement in Germany during the COVID-19 pandemic and how policy lessons from this were acted upon. To then sort of bring it all together, David Clarke, also a co-author on the brief of the World Health Organization headquarters in Geneva, will then share his insights from a global perspective to outline the exciting work WHO is currently doing to support countries in working with the private sector at the global level. So, as ever, we will then have plenty of time for your comments and questions from the chat box. And please don't be shy, ask your questions, and we welcome your comments, insights, and country experiences too. The chat box today will be moderated by my lovely colleague Astrid Eriksson, who will now introduce a poll question for you all, so we can have a little insight into your thoughts out there in the audience. So, Astrid, over to you.
Much, Erica. Yes, we have indeed prepared two questions for you today to sort of kick things off. The poll should appear on your screen in front of you right now. And we would really like to know two questions. One was working with the private sector, an important policy area for the health system in your country before the pandemic. And this is a simple yes and no answer. And the second question is, how did health systems in your country engage with the private sector during the COVID-19 pandemic? And this is a multiple choice question. So you have the answers in terms of research, procurement, developing digital health tools, private providers providing publicly funded services, contracting private enterprises to provide non-health services, none of the above, or all of the above. So let us know your thoughts, and back to you, Erica. Thank you.
Thank you very much, Astrid. So we will give you time to answer the poll, and Astrid will come back with the results after Gabriele's presentation. So without further ado, I would like to hand the floor to Gabriele Pastorino. Thank you very much, Gabriele.
Thank you for this opportunity to very briefly present our work on governing the private sector engagement in health policy and practice today. So the policy brief that I'm going to present on behalf of the author team was developed through joint work and collaboration between the WHO Regional Office for Europe, WHO headquarters, and the European Observatory on Health Systems and Policies. Next slide, please. So we know that the private sector made major contribution to delivering and maintaining essential healthcare goods and services during the COVID-19 pandemic, as it was mentioned in the opening. But we also know the health system are very likely to continue to draw on this private sector capacity going forward. And it's therefore important to learn from the COVID-19 experience to ensure that this relationship work as intended and to address some of the challenges that emerged during the pandemic experience. What the policy brief does not seek to do is to provide recommendation or conclusion on whether or not it's desirable for publicly funded health system to engage with the private sector. On the contrary, the aim of this work was really to analyze some of the available evidence from the pandemic experience, identify the relevant issue that has been shaping this engagement, looking at both positive and negative examples, and set out the policy implication on governance for those policymakers who may want to engage with the private sector in the future. So the objective was very much to draw out lessons for strengthening different aspects of governance and avoiding potential pitfalls. Next slide, please. I would like to start by showing this overview table, that is table 1 that you find in the policy brief, which presents a qualitative selection of the different type of private sector engagement carried out within the European region in 2020 and 2021. This selection is derived mainly from information that is available on the COVID-19 Health System Response Monitor, and is not meant to be an exhaustive inventory, but rather was designed to convey the message that actually most European countries experience a wide range of interaction and activities with the private sector during the 2 initial years of the pandemic. Next slide, please. From that basket of experience, we selected 9 case studies that we consider particularly policy relevant for the story that they were telling, and also in terms of learning for policymakers. And we used them to illustrate our archetypal experiences of how countries engage with the private sector during the pandemic. So the chosen case studies cover 3 areas. The first one is around delivery, which includes the delivery of health services, namely hospital and ICU beds for COVID-19 patients, as well as the provision of vaccination sites for the administration of COVID-19 vaccines. The second area is around equipment, including procurement of PPE and upscaling of COVID-19 laboratory testing. And the third area we looked into was advanced purchase agreement for COVID-19 vaccines. So each case study has been designed to outline what were the objectives of this private sector engagement and how it was carried out in practice in a specific country and national context. And the aim of this case study was really to show how countries responded to particular governance challenges, which solution they came up with, which resulting impacts, and we use those examples to then distill governance lessons. And next slide, please. In the first area of delivery, I would like to mention the case study we had on the Lombardia region, which is about the upscaling of acute hospital and ICU beds, and also very interesting, the contribution that the public authorities requested to the private sector to support the region vaccination campaign by establishing vaccination centers. And we thought it was a particularly interesting example because Lombardia region is one of the most populated in Italy, is about 10 million inhabitants. And this experience was quite unique. The 2 governance lessons that we got from this experience is that harnessing the private sector capabilities should be done in a way that effectively engages the private sector in full alignment with what are the main health system goals and priorities. And the second governance learning is that this goal alignment and compatibility should really be seen as key driver in establishing this collaboration. And this entails a number of concrete things. First of all, setting out from the outset clear objectives for both the public and the private sector actors, identifying how both parties can achieve their objectives within a collaboration, and identify from the outset also appropriate incentive for the private sector, because as we know, value for money is a recurring concern in these experiences. Next slide, please. In the area of equipment, we have been looking at the experiences of Lithuania and their fast-track procurement of PPE, as well as what Estonia has been doing in upscaling the COVID-19 laboratory testing and diagnostic. Those case studies really showcase that transparency and accountability are crucial in ensuring that private sector contracts are governed in a robust manner. Open and transparent information is obviously closely linked to public trust, and we know how much public trust was put in danger during the COVID-19 pandemic. Is needed to safeguard the integrity of those actors and government bodies that are using large amounts of public funds and taxpayers. And clear and transparent processes must be followed, not only to identify and consider potential private sector partners, but also to justify the choices that are made when awarding contracts. So that's also a general public concern about the risk of potential corruption can be addressed. And this is particularly critical in the area of public procurement, of course. Next slide, please. We also had, oh, actually, sorry, there is one slide. Yeah, exactly. Thank you very much. We also had two interesting case studies from Germany and the United Kingdom around the fast-track procurement of face masks and the use of a VIP lane to expand the supply of PPE. Both cases were rather controversial, and they give a very clear indication that establishing emergency procurement guidelines for crisis contracting should be done now by countries in time of peace, and not waiting for another crisis or emergency, because it is now the time that countries can use to really establish clear guidelines for the application of emergency procurement, set out its legal basis, also working to prevent companies and potential supplier and establish robust selection criteria, creating public available registers of call of tenders, and many other things. And all this should be done to avoid situations as the one we have seen during the COVID-19, where there were instances in which contracting was made, which was not out of law, but was a clear conflict of interest, although legal according to the legislation at that time. And we have seen actually countries taking steps and even parliament voting laws to changing procurement practices. Next slide, please. The third area, which look at advanced purchase agreement, we look obviously at the very famous case studies of Israel contract with Pfizer-BioNTech, and as well as the arrangement made by the United Kingdom and the European Commission on their APA for COVID-19 vaccines. Here, the take-home message is quite clear. Equitable risk sharing is very important for accountability and protection. And those experiences really shows that it needs to be explicitly addressed in private sector engagement, and particularly in this kind of contracting. So agreement should cover the full range of risk, which not only include the health risk, of course, and the financial risk, but also what we call the fulfillment risk. So ensuring that there are recourse measures in the event of delays or failures to supply the goods or services that were agreed and stipulated in the contracts, and giving countries, the public sector, ways to react to that. So this ensures not only that the interest of the public sector is adequately protected, but also contributes to minimize loopholes and ambiguities, even in instances where sometimes some of the details of these safeguards may not be disclosed publicly because of commercial confidentiality clauses, as we have seen, for example, in the case of the deal negotiated between Israel and Pfizer-BioNTech. In short, equitable risk sharing protects public payers and strengthens private sector accountability. So I've got my very last slide, which is a summary of the take-home messages that we got from this work. We have seen that the private sector resources and expertise can enhance the delivery of health goods and services. We have seen it during the COVID-19 pandemic, and we had to learn from those experiences to do better in the future. Effective private sector engagement requires good governance practice as the bedrock of having these experiences working in the way they should. The nature of the private sector collaborations should be explicit from the outset, so to ensure good alignment between the goals of the collaboration and the overall goals of the public health system. Transparency and accountability are the bedrock of this relationship, and establishing emergency procurement guidelines for crisis contracting should be done now to be better prepared for future emergency. Building transporting partnership between the public and the private sector is invaluable. It can really help ensure this alignment of goals. And finally, as I just mentioned, the equitable risk sharing is a very important element for both accountability and protection, and need to be explicitly addressed in private sector engagement. Thank you very much for your attention and for the opportunity to present this work.
Thank you very much, Gabriele, for that fantastic overview of the contents of the brief, but also to sort of like foreshadow some of the interesting examples that we've got coming up now from our spotlight presenters. But before we jump to that, Astrid, I'd like to ask you to join us so you can talk about the results of the poll. Thank you.
Thank you, Erica. Yes, the result of the poll is indeed in, and regarding the first question, whether your country was working with the private sector on important policy areas before the COVID-19 pandemic, the majority has voted yes, that was indeed the case. And in terms of the second question, how did the health system in your country engage with the private sector during the COVID-19 pandemic? The majority of participants today has indicated that it was in terms of private providers providing publicly funded services, and procurement, contracting private enterprises to provide non-health services, and research. Thank you.
Thank you very much, Astrid. Yes, very interesting results. Particularly the fact that a quarter of the countries represented here today, they didn't particularly engage with the private sector. So that, I find that quite interesting, because from the work that we've been doing in Denmark, that seems quite surprising. So let's jump onto the spotlights, and we'll go over to Ireland, where Sarah Burke is going to tell us about some of the things that were going on there, particularly around private providers providing publicly funded services. So thank you very much, Sarah. Over to you.
So thanks a million, and thanks to the Observatory for the invitation to present on Ireland's lessons from this safety net agreement with private hospitals, which occurred during wave 1 of COVID-19 from April to June 2020. And this research draws directly on academic research carried out by Lishna McAneil, whom I supervised as a strand of Irish Health Research Board Foundation's research. And this research looked at the policy process that led to the takeover of private hospitals for the first 3 months of the pandemic, not specifically through a governance lens, but in my second slide, I will have some concluding talks through that governance lens. Ireland, let me just do this now, entered the pandemic with a really overstretched public hospital system operating at over 100% occupancy, with low numbers of hospital beds and critical care beds. At the end of 2019, COVID-19 was added to the list of infectious diseases, and this legislation enabled emergency prevention measures, but also exemptions from hospital charges for all patients, which was important for this agreement. In March 2020, the Irish public health system, the HSE, entered negotiations with private hospitals, resulting in this safety net agreement, which meant, in effect, the public takeover of all private hospitals in Ireland from April to June. And under this agreement, all patients were deemed public patients, granting universal access to both public and private hospitals, and adding a significant additional capacity to the whole system. Throughout the pandemic in Ireland, but particularly in the early months, the government had this very strong public policy push of us all being in this together and leaving no one behind. And the engagement of the private hospitals was that was key to driving that engagement. Under the agreement also, the privately practicing consultants in the private hospitals were offered public contracts, and no private work was permitted for the 3 months of the contract. And at the same time, the government postponed all but essential care across the health system. During the 3 months of the safety net agreement, private hospitals were used for urgent and time-dependent cancer, cardiovascular care, transplants, but also treatments such as chemo and radiology. And what we saw were public and private medics and teams working across the system, as the public hospitals were retained largely for the care of patients who had COVID. The private hospitals had work going on, but they were by no means working at full capacity. It also meant that the agreement meant that private hospitals had stable income during the pandemic and prevented them from substantial financial loss. The COVID surge, the demand for extra beds and ventilators that we saw in Italy and New York did not happen. And as the cost of the agreement became public, there was criticism that it wasn't a good use of public money. It was, however, as the deal was called, a safety net, which was never actually fully needed. So if we take a step back from the case study and look at it through a governance lens, what do we find? And in the area of policy capacity, what we find is this rapid implementation of a policy measure that would have taken months or indeed years in peace or non-pandemic times. But what we also found was very unclear policy lines of engagement between the public and the private sector, and in particular, very poor public sector knowledge and understanding of the private sector. And a good example of that came out from the research was a lot of time and effort and detail went into the agreement with the private hospitals, but then they realized the consultants were privately practicing contractors and they had to provide a separate mechanism for the consultants to be able to work under this agreement. In terms of transparency, there was very little. It was a deal done very quickly behind closed doors. And while the heads of terms of it were published, the contracts or none of the details of it have been published. The private consultants who did not take the public contract were particularly critical of the agreement, as they were not able to treat their private patients during this time. And while the overall global spend on the agreement is in public domain, there is very little detail on how this money was spent. Finally, in terms of learning and reflecting back of what's happened since then, there's been huge public investment in our public hospital system, increasing numbers of doctors and consultants, hospital beds, and in particular critical care beds. And yet we continue this contracting of the private hospital sector, especially to address the backlogs caused by COVID in terms of waiting lists and trying to improve access to care. But what we continue to do is have these as very ad hoc or short term rather than the longer term clarity which the private sector expressed was a requirement for them. So I'm going to leave it there and look forward to further discussion in the Q&A.
That's wonderful, Sarah. Thank you so much. Really, really interesting, particularly how the deals were done and how they were received, later on in the pandemic. So moving on without further ado to a story that was hinted at in Gabriele's presentation, but we're going to get a little bit more detail on the story now from Anna Moresso, who's going to talk about procurement in Germany. So Anna, thank you very much. Thank you. Over to you.
Thanks, Erica, and thank you, everyone. So, as mentioned before, this case study on Germany is on the fast-track procurement of face masks during the pandemic. And it was one of the case studies that contributed to generating some very valuable lessons on the importance of transparency and accountability in procurement practices, and how these underpin integrity and safeguard against potential corruption. It's important to note too that it's by no means the only example during the pandemic, and many other countries had similar experiences and challenges. The first thing I'd like to say is talk about a little bit about the context, which we call crisis contracting. During the pandemic, as you all know, most countries had very limited capacity to produce face masks and other PPE items domestically. And at the same time, demand in both national and international markets were exceptionally high, and there were disruptions to global supply chains, and this led to widespread shortages. And in this context, policymakers saw the need to act swiftly and in an agile ways to secure purchases to protect public health. And it's also important to note that in the emergency situation of the COVID pandemic, there was national legislation, and in the cases of European Union countries, there was EU guidance on the options and flexibilities for public procurement, which did allow actions such as truncated timeframes for tendering, as well as direct contracting without the need for public tenders. So that's important to note. So what happened in this case study in Germany is that private sector capacity was required to rapidly acquire protective face masks, and they had to be distributed across the German population very quickly. And there was a variety of avenues that we used to source the required quantity of masks. However, from around March 2021, there were several high-profile cases of German politicians and parliamentarians being directly involved in securing contracts with private sector firms to supply face masks for government agencies, which were paying for these using public funds. And from a governance perspective, several challenges were apparent and are apparent. The main concern that dominated public and strong media attention at the time focused on allegations of inappropriate lobbying by these individuals on behalf of mask suppliers, and by extension, allegations of corruption and bribery. And particularly, there was a question about the legality of these politicians receiving financial rewards or commissions from private companies for securing the contracts. So in one case, for example, that went to trial, Germany's Federal High Court of Justice heard evidence that a company was actually headed by one of the politicians as its CEO, and that he had received, over 600,000 euros through mask procurement activities. In a second case, there was a politician who was closely affiliated with a company that received around 1.2 million in contracts from the German federal government and from the Bavarian state government. Eventually, in the judgments of these two court cases, the court ruled that under the current German laws at the time, both politicians were acting in the interests of the companies that they were working for. That is, that they were involved in the mask deals as part of their company roles, and not under their capacities as parliamentary mandate holders. This might be surprising to some people, but the conclusion was that the actions were therefore not unlawful, and the accusations of bribery were not substantiated. Importantly, however, the court also ruled that if the Parliament considered that these cases exposed a gap in criminal law, a loophole, then it would have to take actions to address this omission. So in the end, the judgments did identify the need for Parliament to clarify rules applying to those in public office. I think it's important to note too that this experience in Germany did lead to some new measures to strengthen public scrutiny and accountability, and the need to build public trust, especially in the political sphere, was a major impetus. Let's note first that there were some existing accountability measures already in place at the time, Both the cases were investigated and they were referred to the courts to determine whether the activities were unlawful. And while the investigation was taking place, the politicians involved were required to resign from their parliamentary mandates and their party posts. Also, during the unfolding of these events, the political parties, so the politicians belonged to, bolstered their efforts to increase transparency. I see I only have a little bit of time left, and to restore trust. So they put in some new policies to make their members declare financial benefits that they had in connection to the pandemic. But my last point is that, importantly, after the court ruling, this experience led to stricter rules and regulations on the detailed declaration of financial interests of federal parliamentarians. And additionally, there was more detailed and transparent rules now apply to declaring indirect involvement with corporations and private companies by German politicians. And the penalties for parliamentarians convicted of bribery or persons trying to bribe them have been upgraded to criminal offences. So as a positive outcome, we can see that these measures address some of the ambiguity that had surrounded the roles of parliamentarians at federal level, and they provide a better understanding of conduct and responsibilities, particularly with regard to lobbying on behalf of enterprises in which politicians have financial stakes. Thank you.
Thank you so much, Anna. Yes, it's a really interesting case study in terms of how accountability works and how governance can be strengthened once it has been tested. Okay, so let's hand over to David. David is going to tell us about the work that WHO is doing to strengthen governance globally in this area and what we should all be learning from each other. Thank you very much, David. Over to you.
Thanks, Erica. I think what we've heard from the colleagues about the policy brief and about the case studies really underlines that when it comes to working with the private sector, this is probably a very understudied and under-resourced area of governance. A lot of our work focuses on supporting member states in low and middle income countries. And I can tell you that in those countries, the capacity to work on this area needs to be strengthened. So a lot of our work accordingly focuses on how we can build the governance capacity of countries to work on these topics, to deal with these challenges and problems that you've just heard about. So what we're doing at the moment is to provide very practical help and support to work out how to work with the private sector, how to build trust, how to use policy instruments and create accountability for this work. We've heard that even in the European region, this caused some challenges. We are working on a progression model, which is designed to provide member states with information so they can make their own judgments about their existing capacity to work on this topic and how they can build their capacity over time to do better. The reason we did this work is because, not just because of COVID-19, but because in the context of health systems work generally, we have seen that when we look at the SDG goals and targets, we are way behind when it comes to working towards these goals and targets. We also see that the private sector in some WHO regions provides over 60% of health services. So we simply can't ignore 60% of the health system. Therefore, we have been progressively doing work at the request of the World Health Assembly to support countries to do better in this area. Just to highlight some of the things that we've done, in 2019, we set up a technical advisory group to help WHO work out how to approach this topic in a very strategic way. That group issued a strategy report in 2020. During the COVID situation and hearing about the challenges that many member states were facing, we set up a platform called the Country Connect on the private sector and health, which is still running. Originally, it was focused on COVID and the COVID response, but also in maintaining essential health services. We did a lot of work at the time on maternal and child health and how those services particularly suffered because health service capacity was concentrating on on the COVID response on non-maintenance and essential health services. So we did a lot of work back then to find ways to support countries to how to grapple with the policy and governance issues associated with this. We're still running that platform, and now it's being changed, so it looks at health service provision more generally, focused on the SDGs and focused on universal health coverage. And now we've moved into this phase of work where we developed the progression model. The progression model has been developed over about a 2-year period. It involved using a massive scoping review that we've just completed, and also involved some pilots in some WHO countries. We're about to engage in some further pilots. We're aiming to do a pilot in the European region, a pilot in the African region, and a pilot in the Eastern Mediterranean region, which will provide us with better information about whether or not the progression models fit for purpose for country use. Our initial feedback from our experts and from countries who have looked at it and used it is that it's very useful and timely, and it's definitely something that we want to put a lot more effort in going forward. I think our observation is that when it comes to health systems governance, there are many great frameworks and theoretical underpinnings for this, but when it comes to the actual practice of governance, things are rather thin. And therefore, this is one of the reasons that we're focusing now on the very practical and practice aspects of governance. So once this document and the scoping review is released, it should be released in about a month, you'll see that we're honing in on the very specific practical aspects, very specific practical tools and problems that countries face when it comes to working on this topic. I'll stop there because I want to give plenty of time for people to ask questions. So there's a PowerPoint which explains the bigger story behind this work that colleagues have kindly shared in the chat. I can also share further information about our global work on this topic. Thank you. Thanks, Erica.
Thank you so much, David. Thank you. So very rich, a lot of ground being covered here in all our presentations. If I could ask the panelists to all put their cameras on, and Astrid, if you could feedback some of the questions. It's been quite a lively chat box, hasn't it? So please do continue to post your questions. Hopefully we'll have time for a second round of questions, but I recommend you get your questions in early to avoid disappointment. So Astrid, what's coming up in the chat?
Thank you, Erica. Yes, it has been a lively chat. And I want to sort of summarize it with 3 questions. So what is the role of international organizations in working with the private sector? How can they work to improve transparency? And then we have a specific question. Sarah, we heard a spotlight on Ireland earlier, but are there sort of broader national learnings from Ireland that we can learn from? And then we've heard examples from various countries on how they use the private sector to deliver and uptake of publicly procured goods during the COVID-19 pandemic. But are there any more examples that we could sort of dive into? Yeah, so that's it from my side from the first round of discussion, but please do continue to post your questions, and yeah, let's see if we have time for a second round. Thank you.
Thank you very much. Thank you. So, Sarah, there was a very specific question for you there. So, do you quickly, what does Ireland have to teach the world about this?
Well, first of all, we're a very mixed system of care, but interestingly, often the private sector is left out of the sort of public policy domain. And I think that was one of the really interesting learnings from COVID, was because of this all in this together element, there was much more engagement with the private sector. And in the case of, well, maybe depending where you're sitting, the private hospitals, largely a positive one in that it provided that surge capacity that wasn't actually needed and that good working across the public and private sectors. There was other areas that we've been very slow, like using pharmacists much more in health system responses. So again, that happened during COVID late, but it did happen in terms of rollout of vaccinations. And I think we're beginning to utilize that more across the health system in terms of the role of the pharmacists as a health system response and them being solely private providers. Another example that emerged during COVID was that nursing homes, and the vast majority of nursing homes in Ireland are privately run and provided. And there was no engagement of the public system, and particularly public health, until COVID. And obviously, it was one of the areas we fared worst during COVID, was the high numbers of deaths in the nursing homes. But it means now there is much better public sector cooperation with the private nursing homes, with engagement of public health medics in terms of infection and control. So a positive learning coming out of that as well.
Thank you very much. Yes, I suppose that is the key issue, isn't it? It's that the pandemic provided these external stresses for the system in terms of governance and all sorts of different areas, really every aspect of the health system. But it's what we then do with that.
And just to loop it
forward from that and learn.
To loop it back to the one I was talking about. So we did use the private hospitals for those first 3 months, and we continue to use them. But again, we continue to do it on this ad hoc, maybe not very consistent way in terms of a response now to long-term waiting lists. And that really there needs to be much better proactive engagement with the private sector to do that in the public interest. And we haven't seen that yet.
Okay, Sarah, thank you. So this is probably one for Gabriele and David. So the role of international organisations in all of this. So is there one, or is this a national competence?
It's an international issue. I mean, in 24 years ago, WHO published World Health Report 2000. And in that report, they introduced this concept of stewardship, which squarely said that governments had to take responsibility for their entire health system, both the public and private aspects of it. But in fact, what's happened, and Sarah just highlighted this, the private sector's often left out of government's public policy and plans. And the perspective that we're taking with our work at WHO is that governments should take responsibility for ensuring that the public policies that they want to implement involve both the public and the private sectors. We have to work with the health systems we have, not the ones we might want. So I think I highlighted in my presentation that many of the world's health systems are over half private. And if we don't work with them by using appropriate policy tools and take responsibility for stewarding the whole health system, then we're not going to get to the SDG goals and targets. And I think it's really beholden on organizations like WHO to work on this, because I think we're the one organization that comes to this without a vested interest. So WHO is about the right to health and making sure that people have access to health services they need. So our work in this space is about that. It's about supporting countries to make sure that they use all the health system to help people to achieve the right to health. Other international organizations have a different perspective on this. Some of them are promoting the private sector. Some of them are promoting things like public-private partnerships. But I guess for WHO at least, we are the one international agency who can actually have a voice in supporting countries to promote the importance of taking on this topic as a serious public policy issue. I'll stop there.
Thank you very much. Gabriele, is there anything you would like to add?
Yeah, I would like to echo what Dave just said. I mean, we have a role. I think the shift in the thinking is that we cannot shy away from this issue. We cannot shy away from the need to interact with the private sector, whether we like it or not. I mean, public health systems have to learn to deal with it and to deal with it the best they can. We have seen a symmetry of capacity in negotiating the terms of this, many of these arrangements. And for this reason, actually, the COVID-19 experience was fascinating, because even countries that are predominantly or fully run by public, the public health systems, they had to rely somehow, in some ways, on private resources. And so that was an example of even those systems had to deal with those challenges. We have a mandate as an organization. We have a mandate in the European region given by the European Program of Work. But the mandate is about strengthening health system governance. And I think in Europe, we have been really trying the last few years to move to very concrete work in this area, and the private sector. And this piece we've done with the Observatory and in collaboration also with Data and Headquarters is a good example of that. I mean, we want to tackle practical issue and actually work with policymakers to resolve very pragmatic policy issues and not, you know, providing them with another framework which can be very fascinating and intellectually stimulating, but we are here to actually support countries to resolve very pragmatic problems. So I think the interest and the role of WHO in this field will grow in the years. Thank you.
Thank you very much. Thank you. So, Anna, is there anything you'd like to add, or should we jump straight to the next round of questions?
Just to say that the question on other procurement examples, there's quite a few in the policy brief. In the table, you'll see that many countries were involved in procurement with the private sector. There's many other examples, including, for example, you know, on the UK and their use of the VIP lane in procurement of PPE. And the point there is that the policy brief has some very concrete recommendations on how to achieve transparent and accountable processes in emergency procurement. You will find them in the policy brief, and that would largely avoid the kind of governance risks and lack of transparency and accountability that these examples have brought up. So I recommend the person who asked the question to have a look there, but there are definitely concrete recommendations in the policy brief. That's all. Thanks.
Thank you very much. Thank you. Yes, and I do believe that the link to the policy brief has been posted in the chat box, so you can read it at your leisure. Okay, Astrid, back to you. Round two. Things have been popping up in the chat.
They indeed have, and I will start with two questions because it's active and I can't keep up. So maybe we can do two questions and then see if there's time. We had one question regarding the relationship between governments and the private sector and how to encourage greater collaboration between the two. Did you see any examples of this in your work? And if so, could you drive in some of these examples and tell the audience more about it? And then coming again back to transparency, I think that people really want to know if what in the panelist opinion, what can the European Union also do, for example, in terms of improving transparency? Yeah, so over to you, Erika.
Thank you very much. Thank you. Big questions there. So briefly, who wants to jump in first? Who's feeling bold?
I'll come in just to get it over with, Erika. So I think one of the real learnings from the Irish case study was that there weren't agreed sort of principles and rules of engagement pre-COVID, and therefore it happened very quickly, long overnights in a very short period of time. And a certain agreement came out, and that only lasted for 3 months. So for us to learn from that, there needs to be, I think, much clearer, as I said, rules of engagement, principles that work in the public interest, but that allow the private sector to be on board in normal times, but then that there's a clear process of engagement in whatever they are, non-normal crisis times, pandemic times. And I think key to those is the transparency and the accountability loops, that for the public and for the politicians and for the health system to engage, those transparency and accountability loops need to be clear. And I think the WHO and Europe can do a lot at a leadership level around that, but I think ultimately that needs to be agreed at national level between key players and the departments of health or public expenditure and reform.
Okay, so Anna, David, who would like to jump in?
When it comes to governments, I think that this whole question of the relationship between governments and the private sector is pivotal. We've heard from the pandemic situation that before the pandemic, some governments, and even after the pandemic, haven't been that keen on having a formal set of rules and around engagement or any kind of systematic process. We would certainly be advocating at WHO for that. In fact, we have actually got a WHO resolution which asks for our member states to provide them with support in this area. So that's why we're working on it. And when it comes to individual government decision making, I don't think we can come up with a set of rules which applies to every country, because we're dealing with everybody from very high income countries to very low income countries where there's no public sector and it's all private. So we have to find a way to provide information to countries to support decision making that makes sense for their context in a way which is appropriate and involves not just the government and the private sector, but also civil society and populations. So that's why we're working on as much on process as on the content of the rules. So that's, I guess, why with the progression pathway work, we're trying to provide a structured way to put together a country-specific approach to the private sector. Countries have to make their own decisions about this, but we do want to support them to make really good decisions. Because at the moment, decisions are not always made in a very systematic or logical way. We've heard that from many of the panelists today. They tend to be made, the decisions have been made in that hot way rather than in a logical and transparent way. And I just want to very quickly talk about the transparency and accountability issue. And for me, one really big thing that we can do, and that maybe the European Union and WHO can do about this, is to work on the quality of data about the private sector. At the moment, there are massive data holes when it comes to the operation of the private sector, particularly in low and middle income countries. And that's an area where we think we need to do far more work. It's really difficult for governments to make any kind of call on how to respond to private sector activities if they don't know what's going on. So for us, I think that would make a huge difference in terms of accountability and transparency. Better data is something that we would really call for.
Anna, you've got 30 seconds to say something about cross-country learning. Is there anything you'd like to add?
Well, I just wanted to add that part of the cross-country learning is exactly the point that David made. The information needs to be in the public domain. So, and put up platforms such as, we have the platform that David has referred to, but countries themselves, they need to publicize on websites, even not only in areas of procurement, but in all innovative areas where they want to engage with the private sector, the types of projects they're doing. Of course, there are sometimes confidentiality issues, but putting the information out in the public domain is not only ensures accountability and transparency, but gives us the resources with which to learn from one another.
Thank you very much, Anna. Thank you. So, Gabriele, if we learn nothing else today, what is our take-home message? What should we bear in mind for the future in our ministries around Europe?
Well, I think from the questions we got in the chat box, for me, it's a great confirmation that this is a relevant topic that sparked a lot of debates. We also see when we launched the publication in UFA in November. It's a complex topic, and it's something that we are very much committed to work more going forward, both in terms of collecting evidence, but also to support countries on technical assistance level. And I think the take-home message is that we cannot shy away from this engagement. It's in the facts, but we need to prepare the public sector to be fit to negotiate, to get good deals, to bring the private sector to deliver what the public sector needs, and to get the public sector to deliver for the health system public set goals. I think this is really what we have to bear in mind, and the polar star in dealing with this very important issue. Thank you.
Thank you very much. A really great message to go home with. So all that leaves for me to say is thank you so much to all of you in the audience for joining. Thank you for your engagement. Thank you for your questions. Thank you to Astrid Eriksson, my observatory colleague based at the Technical University in Berlin, for dealing with the chat box. Very many thanks to Gabriele Pastorino of the WHO Regional Office for Europe in Copenhagen, Sarah Burke, the Trinity College Dublin in Ireland, Anna Moresso at the European Observatory on Health Systems and Policies, also based in Berlin, and David Clarke from the World Health Organization in Geneva. So thank you very much, and I'll see you all next time. Take care now. Bye-bye.